Okay, we are going to start the procedure of reducer implantation today. With me here is Dr. Sami Bazan, who is going to do the procedure. I'm going to help him. The first stage after inserting the 9 French sheath into the jugular vein is to take a multi-purpose diagnostic catheter, flush it with saline, and measure pressure in the right atrium. So Sami is going now to insert the catheter into the right atrium. We usually do it without need of a wire, if possible. And here we are in the right atrium. We're going to measure the pressure. Take the air out. Flush, please. 0. Okay, now pressure. We're looking at the mean pressure in the right atrium. The mean pressure has to be less than 15. Boris, please give me the mean line. If the mean pressure in the right atrium is higher than 15, we abort the case. We don't do the case because the pressure is already too high. Here the mean pressure is around 7 or 8, so we are fine, and we can continue with the procedure. So the next step is to take a 10 ml Luer lock syringe and try to engage the coronary sinus the way Sami is doing it. Straighten his hands, straighten the multipurpose, and trying to go from 11 o'clock towards 5 o'clock, giving little test of contrast until he finds the ostium of the coronary sinus. So Sami is trying to engage the ostium of the coronary sinus. He's taking the multipurpose catheter, slowly Sami, from 11 o'clock to 5 o'clock. He gives a little test of contrast. When he's in the coronary sinus, he tries to go forward and advance it by rotating motion of his hands, trying to go inside. If it doesn't go, we stop, we never push, and we will take a wire. But as you can see, the catheter was stopped on a valve in the coronary sinus. The way to overcome the valve and advance the catheter is never to push. It's only to rotate and wait, rotate and wait. The valve will open, and as you see, the catheter is jumping inside by itself and goes all the way in. So now we're ready to take the first angiography. This is a rule. Every time before doing a force injection and angiography in the coronary sinus, we take a little test of contrast. We take a little test of contrast to see that the tip of the catheter is not in a small branch. So now we are in a small branch. So Sami, take backwards a little bit. Check that you are not in a small branch, and then take a full angio. Very nice. Okay, let's do another thing. Let's take a wire, go deeper into the great cardiac vein, and take another angiography. We see pretty good. It's a pretty nice coronary sinus, but I want, for the purpose of this video in this case, we'll try to get even a better shot. So Sami is taking J wire, going into the great cardiac vein, which is around 12 o'clock. Right there. Take the catheter there on the wire. I'm holding the wire for you. Okay, that's it. Very nice. Now I'm taking the wire out. And we'll take another angio. Again, this time, as in any time when we take angio, before injecting, take a little test just to make sure that you're not in a small branch. Because if you will force inject into a small branch, we'll have a extravasation. We don't want it. Okay, angiography. Hazak. Very nice. Okay, so we have the shape of the coronary sinus. We never want to implant by the ostium because the coronary sinus is very wide there. we never want to implant very deep at the great cardiac vein, because the coronary sinus is going in parallel to the circumflex artery. We will implant right on this vertebra. Right after the coronary sinus take an angle up, we take this vertebra as a bony marker, and we will implant right on this vertebra. So as soon as we have this as a bony marker, we don't have to inject any more contrast. Boris, do you want to do a QCA, please? Now, when we decide that we are going for implantation, we give heparin to the patient. So now, Yael, please give heparin to the patient, 5,000 units, and let's open the system. QCA, the diameter of the coronary sinus at the site we chose for implantation is around 7 millimeters, which is good. QCA sometimes underestimates, so the true lumen of the coronary sinus is probably more than 7 millimeters, but I will show you how we check it properly. Now let's open, I'll show you the device. First we have the reducer. It comes covered with a long plastic tube. I take it out of the tube, and this is the reducer. It is covered with a plastic sheath, and it has a metal membrane. I take the membrane out, and I take the plastic cover sheath out. I check that the reducer is well located between the distal marker and the proximal marker, and I flush it. I flush the lumen. Okay, I flush the reducer. Okay, and I put it aside. It is ready. I also have the Y connector and a straight 9 French guiding catheter. So I take the Y connector, connect it to the guiding catheter, and then I have to reshape the guiding catheter to give it the shape of like the acuity catheter has, a dedicated coronary sinus catheter, without kinking it, without breaking the catheter gently. I'm giving it slight pre-shaping so it gets shape of slight angulated, okay, like that. Now I flush the guiding catheter. On both ends. Okay, and we have the guiding ready. So we have now the multipurpose in place in the coronary sinus. What we're going to do next is take a long J wire. A long J wire, Sami will insert it through the multipurpose catheter all the way deep into the coronary sinus and into the great cardiac vein, and we will withdraw the diagnostic multipurpose catheter out. So the wire is going in, wire is going in, all the way in, and the multipurpose out. Up, up, up. Almost lost the wire. Okay, very nice. That's it. Must speak. Okay, so we have the multipurpose out, and the wire is deep in the coronary sinus. I'm going to flush the multipurpose because I'm going to need it right now. I'll show you how. I take the multipurpose and I put it inside the guiding catheter. We're going to do a telescope or a mother and child technique. So the multipurpose is much longer than the guiding. We extend it and we lock it here. So I lock the multipurpose and the guiding, and now Sami is going to get the multipurpose on the wire. He's putting the wire through the multipurpose. I'm waiting for the wire right here. And as soon as I'll get the wire, like now, I'll take the wire and I'll give Sami some tension on the wire. And he is inserting the multipurpose and the guiding catheter on the wire. So we go with the multipurpose over the wire. I put some tension on the wire. Here we have a valve, so we have some resistance for the multipurpose to go in. What Sami does, never push, just rotate and wait. The catheter will jump in. We put again the multipurpose in the coronary sinus with the wire, and now we are advancing the guiding catheter on the multipurpose, mother and child technique. And again, we're stuck on a valve. So the way to cross the valve is just to rotate, not to push. Never push. Maybe you crossed it? Yeah, you crossed it. Okay, so now we can advance. And we advance the guiding catheter distal to the point we want to implant. Just a second. We go with the guiding over the multipurpose. That's fine. Okay, now we're fine. I take the multipurpose out and we leave the wire and the guiding in, and now we are ready for implantation. You can see that the tip of the guiding catheter is distal to the point, hold it, we want to implant. I have the multipurpose in my hand. I'm going to flush it again because we will need it at the end of the procedure. So I'm flushing it and keeping it in the water. Preparing the indiflator is only with 20% contrast and 80% saline. So what I do, I put a stopcock to the end of the indiflator. I take 2 ml of contrast in a 20 ml syringe, fill it to a 10 ml total with saline, and suck it all into the indiflator. So now I have in the indiflator prepared with contrast to saline 20 to 80%, and this is ready with a stopcock at the end. Now we have the guiding catheter distal to the point we want to implant. We have the wire inside and we are ready for implantation. Now we will take the reducer. At the Y connector of the guiding catheter, we will put a 10 ml syringe with contrast. So we have a 10 ml syringe with contrast. One thing that is very important, is when you bring the reducer through the Y connector, is to open wide the Y connector, let it bleed out, so you bring in the reducer into the catheter and the Y connector without any friction. This is very important because friction can move the reducer on the balloon, and then if it is unnoticed, the reducer will not be implanted properly. So what I'll show you how it's done. What Sami is going to do now, put the reducer on the wire. I'm waiting for the wire at the other end of the reducer. It's an over-the-wire system. As soon as I have the wire, I keep the wire with some tension for Sami. And now Sami is going to get the reducer through the Y connector, and when he does it, he will open very wide the Y connector, let it bleed out, don't worry, and get the reducer inside without any friction. After you're in, you can close the Y connector and stop the bleeding out. Okay, So I'm holding the wire with some tension, and Sami is going inside the guiding catheter. Going in with the reducer inside the guiding catheter, stop. We stop at the right atrium, and this is very important step that I must emphasize. When you arrive to the right atrium, stop, take a cine of the reducer. Sami, please take a cine of the reducer. Okay, we check to make sure that the reducer is well located between the distal and the middle marker, and it has not moved on the balloon, because if we have a suspicion that the reducer has moved on the balloon and it's not properly located between the markers, the only thing to do is to take out the guiding catheter and the reducer inside and leave the wire in place. Never try to take only the reducer outside and leave the guiding in. Take the guiding and the reducer out, start over again with a new reducer. So we took the picture, we took the cine, we see that the reducer is well located between the markers, so we can continue. We have a syringe, Luolok syringe with contrast at the end of the Y connector, at the end of the guiding catheter. We will take an injection of contrast into the coronary sinus when the balloon is fully inflated, just to make sure that we are properly oversizing. What Sami will do now is we'll take the reducer into the site of implantation. I'm connecting the indiflator. We're not doing a negative on the indiflator. And Sami will advance the reducer to the site of implantation, which is up to the tip of the guiding catheter. One shot, go in. Go, go, go. Don't worry, go. Okay. Now advance both. Now we will advance both the guiding and the reducer. That's fine. That's fine. Okay. So now we are at the site of implantation, right on this intervertebra vertebra, and we are going to inflate to 4 atmospheres. What Sami will do now is, while I'm holding the wire, he will withdraw the guiding catheter and keep the reducer in place, and the withdrawal of the guiding catheter will be to the most proximal marker. Go ahead, Sami. No, okay, say that. Guiding out to the marker. More. Very good. See, the reducer is right where we wanted it to be implanted. Maspik, Taresha, show me the end of the tip of the guiding. Guiding back. Take the guiding back to the marker. Okay, now I'm going to inflate. We are inflating to 4 atmospheres. Red. Floor. Okay, we are at 4 atmospheres. It takes time until the needle is stable. Needle is going down, I'm inflating. Going down, I'm inflating until it is stable. We wait about 30 to 40 seconds. 4 atmospheres. And now we will take an injection through the guiding to see that we are properly oversizing. We have to check that the Y connector is closed. Go ahead, inject on the cine. Inject. Okay, we're nicely oversized. I can reduce the pressure, deflate, and now we are approaching the most difficult part of the procedure, which is to take the very bulky balloon outside without moving the reducer with us. So what we do in order to do it uneventfully is we take 3 deflation of the indiflator. So if you will take a look, zoom in here, I empty completely the indiflator. That's why I have this Y connector. I empty it completely and I go for another deflation. We do 3 such deflations, and what we also do, we flush the guiding catheter with saline to get rid of the sticky contrast and flush it with saline. Okay, flush. Okay, enough. Leave it there. And let's do another deflation. I empty again the indeflator. Okay, Sami, now please take a cine. You can see the reducer in place. You can see the wire is in place. And now what we will do is we will try to pull out the balloon without taking the reducer without dragging the reducer backwards with us. The trick is that I control the wire, and what Sami does is with his right hand pulling out forcefully the balloon catheter, and with his left hand allowing the guiding catheter to go in and engage the narrow center of the reducer. The guiding catheter will back up the center of the reducer, hold it in place, while Sami is taking out the reducer into the guiding catheter. My job is to make sure that we don't lose the wire, and I keep pushing in the wire. Okay, so now I don't need the indeflator anymore. So I keep it in vacuum, and I take out off the indeflator. We don't need it. I am going to hold the wire, look at the screen, and keep the wire in place. Sami is going with his right hand to pull out the balloon, and with his left hand allow the guiding catheter to be pushed in towards the middle narrow center of the reducer. Okay, under cine, please. Go ahead. The balloon is going into the guiding. As soon as the balloon is in the guiding, I'm pressing on the wire to get the guiding away from the reducer.
Now let's look at the cine again.
I'm going to take over and pull out the balloon from here when Sami is taking care of the guiding only. So I'm controlling both the wire and the balloon. And when Sami gets the balloon out, he will announce. Wire. Okay, so the balloon is out, the wire is in place. We'll flush the wire. Okay, this is a bulky balloon. It's out. We don't need it anymore. We'll put it aside. Okay, we can inflate it for you. So you can appreciate the shape of the balloon. Okay, this is the shape of the balloon. It's a customized balloon. The center is always 3 millimeters, and both ends, the diameter of both ends depends on the pressure we put in the indeflator. So now we are going to take a final angio. And now comes the last part to look at our results. Take a seat and just like that. Please, Sami. Okay, we see the reducer in place, we see the guiding catheter, we see the wire. What we will do now, we will take again the multi-purpose catheter, which is now clean and flushed. We will ride with the multi-purpose catheter over the wire. We will go through the center of the reducer. It will not harm the reducer. As Sami will go through the reducer, I will put some tension on the wire, and it will center it through the reducer. We do not take the final shot through the guiding because the quality of the picture will not be so good. That's why, because it's against the bloodstream. Now Sami goes with the multi-purpose through the reducer. Nice, enough, and I'm taking out the wire. Sine? I'm taking out the wire. Okay, now we'll take a syringe with contrast. Again, before injecting contrast into the coronary sinus, it is very important to make sure that the tip is not in a small branch. So take a little test. Okay, and now take a full injection. Okay, this is good. You see we are oversized nicely in the proximal and distal part. We don't see the narrowing yet because blood is flowing around the neck through the struts. It will take about 6 weeks until the oversizing will trigger tissue proliferation and coverage of the struts and the gaps between the struts. So it will take about 6 weeks to 2.5 months until the patient feels better when the pressure gradient is established. So we are done. We will take everything out, please, Sami. We'll keep the patient under observation for another hour here in the recovery room, and then we'll take the sheath out. And the patient will be on dual antiplatelet therapy with Plavix and aspirin for 6 months, and will come for follow-up at 1 month, 3 months, and 6 months, and then yearly. Thank you very much.